Good evening, sir. Today I am presenting a CNS case. My patient, Mr. ABC, age 62-year-old. She is a female patient hailing from Sirwar, Raichur, working as a homemaker with no formal education, belongs to upper lower class according to modified Kuppuswamy classification, admitted to the hospital on 16th of April and examined on 22nd of April, and she is a right-handed person. Her chief complaints: weakness of right upper limb and right lower limb since 10 days and slurred speech since 10 days. Deviation of angle of mouth to left since 10 days. History of present illness. Patient apparent. Yes, sir.
See, your demographic data is really very nice. And yes, you have told us even 1 week after the admission, you are examining even admission, she took 4 days after the incidents, she was admitted to the hospital. What I would like to suggest to you here is, see, you are telling weakness of the right half of, instead of telling right upper limb, right lower limb, you can say right half of the body, no? The whole right half of the body is affected, is it not?
Yes, sir.
Okay. Continue.
History of present illness. Patient apparently normal 10 days ago. Then she developed sudden onset of weakness of right half of the body, noticed in the morning around 6 a.m. while getting up from sleep. Patient was unable to get up from bed. Initially, patient was unable to do squatting, gripping slippers, buttoning the blouse, and comb the hair. She was able to roll over the bed. Weakness was more in the upper limb compared to lower limb. Presently, from the past 4 days, patient is able to sit in the bed, able to move the limb side to side, can elevate the limb slightly. Still, movement of upper limb is less compared to lower limb. Informant gives history of slurring of speech since 10 days. It is sudden in onset. Patient is able to understand but cannot repeat, cannot name the things. Fluency completely reduced. Presently, patient cannot read aloud and write. It is associated with deviation of angle of mouth to left side since 10 days, which is sudden in onset, associated with drooling of saliva, deviates while chewing and showing teeth. Presently, from the past 4 days, patient is able to take food. There is no difficulty in chewing and swallowing. Patient being taken to the hospital 4 days after the incident. She is on treatment. There is no history of head or spine trauma, no history of loss of consciousness, headache, nausea, vomiting, convulsions, neck pain, altered sensorium, no history of behavioral abnormality, no history of fever. Patient is able to feel the warmth of the cloth, no loss or altered sensation, no history of change in the smell sensation, double vision, appearance of black spots, loss of vision, able to move the eye all around, no history of giddiness, tinnitus, reduced hearing, difficulty in swallowing, nasal regurgitation, drooping of shoulder, no history of urinary or fecal incontinence, no history of chest pain, breathlessness, palpitations, swelling of the legs, no history of drug intake, oral contraceptive pills, no history of bleeding from the nose and mouth. Sir, past history.
Okay, now before going to past history, can you highlight what are the points in the present illness?
Hello, sir.
You
Sir,
need not go on telling again. Can you please highlight the important points in the present illness?
Sir, there is weakness of complete right half of the body. Yes, sir. Hello, sir.
Continue.
Hello, sir. Sir, there is complete weakness in the right half of the body. There is complete weakness in the right half of the body, sir, which is...
Yes.
And there is even features of cranial nerve palsy, sir. That is facial nerve involvement, sir.
Okay. Okay, here what
And,
you should have done in the cranial nerve palsy,
yes.
you should have told that patient can close the eyes, but there is drooping of the saliva, deviation of angle of mouth to the left,
Side.
and patient is finding it difficult to eat. So that you should have told. One thing is closing of the eyes.
Yes, sir.
You have not mentioned because maybe this. Okay, that's one. Next, continue.
Then there is no other sensory other cranial nerves and other cerebellar dysfunction, sir.
Okay, in the history, you have nicely told us about which this thing is affected, because the upper limb is more affected, means it is carotid artery system or the middle cerebral artery system that is affected when compared to the vertebrobasilar. If vertebrobasilar is affected, patient would have had weakness on both the sides, and patient would have had nausea, vomiting, giddiness, hiccups.
Yes, sir.
So that is not there. Okay. And
yes,
another
sir.
important feature you highlighted is there is improvement. In this 10 days, there is an improvement. And
yes, sir.
most important, it has occurred at patient has gone to the bed, but only notice the weakness in the morning, 6 a.m.
Yes,
so
sir.
these are important points when you want to make whether it's an ischemic stroke or an hemorrhagic stroke. So that way it helps you out. Okay.
Yes, sir.
Okay. Next, now continue with the past history.
Sir, past history. No history of similar complaints in the past. Diagnosed as hypertensive on admission to the hospital. Known case of diabetic mellitus since 5 years on irregular medication. No history of transient ischemic attack. Not a known case of bronchial asthma, chronic obstructive pulmonary disease, tuberculosis, ischemic heart disease, rheumatic heart disease, bleeding or clotting disorders, epileptic disease, and peripheral vascular disease. No history of prior surgeries. No known allergies. Then
So,
family history, no history of high.
Okay, why you have taken? No, 1 minute, please stop there. See, why you have put hypertension and diabetes in the past history? She is suffering. I mean, it's continuing, no? Is it not?
Sir.
So what you should have told is known patient of diabetes mellitus for 5 years on treatment, whether she is on regular treatment or irregular treatment, what medications, if you know, that you should have mentioned, and then started the history of present illness. And recently detected to be, or on admission detected to be hypertensive.
Yes, sir.
So it doesn't go into the past history. It comes, is it not? Okay, you have told that there is no bleeding manifestations in the past, or any previous history of TIA. You have told transient ischemic attack.
Yes, sir.
Okay, so transient ischemic attacks are important because you get about 40% of the individuals come with the history of transient ischemic attacks in the past. That suggests that this most probably this is an ischemic stroke. Okay, so that's about the past history. Family history.
Sir, there is no family history suggestive of hypertension, diabetic mellitus, myocardial infarction, and transient ischemic attacks.
Okay, so what you should have asked in family history once again is whether there is any history of strokes in the family, okay, or strokes in the young. So young members of the family are affected with ischemic strokes or whatever strokes that is. If they are given history like that, then it clearly suggests that she must be having some familial disease like familial homosexuality, hypertriglyceridemia, So dyslipidemia. So these things will be thought of when you tell a family history, which is not mentioned in the family history of stroke. Okay. Then
Yes, sir.
next, continue.
Next, personal history. She is a non-vegetarian with the adequate sleep and good appetite, having normal bowel and bladder movement. There is no history of smoking. Consumes whiskey 90 ml per day once in a week. History of chewing tobacco present.
After the history, you are complete.
Hello? Sir, I am not able
Can
to
you hear
hear
me?
you. Yes, sir.
You have completed this. You have completed the
Yes,
history,
sir.
is it not?
Summary. Yes, sir.
No. Before going to summary, in any central
Yes.
nervous system involvement, this is a central nervous system involvement. Patient, you should ask, what is the progress in the hospital? Progress in the hospital. Then you should ask in treatment history. That you have not mentioned any treatment history in the past, or whether there is any treatment history. I mean, here in the
Sir,
hospital.
wrote in history of present illness as she is on the treatment for the present condition.
You have got any details about the history? I mean, the treatment history. You must separately mention about treatment history, like what drugs,
Okay.
if you know, if the patient tells you what drugs.
Yes, sir. Aspirin.
Okay.
She was taking aspirin and clopidogrel, sir.
So, what is the sequelae in this in the condition that you have told little bit in the present history itself, that there is an improvement in the patient's condition, that she can sit.
Yes, sir.
So that's okay. That's fine. Okay. So now.
Yes, sir.
You should be able to use okay.
Hello.
Continue,
Sir, it was not
Tejaswini.
clear. Sir.
So you, after the history, usually the central nervous system examination, by history we diagnose about 70% of the cases, about another 15 to 20% by examination, another 5% after the investigation, 5% goes, I mean, undiagnosed at that present examination. Subsequently, in the follow-ups, you will be able to diagnose. That's the usual thing. So that is why one has to make out what is the lesion, then the lesion, which part of the central nervous system, like is it in the cortex, is it in the internal capsule, is it in the brainstem, is it in the spinal cord, or in the periphery. Then why? The another question is the lesion. So these three questions you have to answer.
Yes, sir.
Tejaswini, can you hear me?
Yes. Yes, sir.
Continue. Continue with summary.
Sir, summary should. Summary: elderly lady, a chronic diabetic and hypertensive on irregular treatment, presented with acute onset of weakness of right upper limb more than right lower limb, associated with weakness of right lower half of the face and slurring of speech of 10 days duration, currently non-progressive. She doesn't have any symptoms suggesting the involvement of higher motor function, other cranial nerves, brainstem, cerebellum, sensory system, bowel or bladder. I consider her to be having right-sided hemiparesis with right upper motor neuron facial palsy, Broca's aphasia due to stroke involving the left middle cerebral artery territory, probably superior division due to thrombotic infarction in the recovering course.
So I will make it further simple for you. Say, for example, what is the lesion?
Yes, sir.
Patient is having left-sided hemiparesis. because she is able to move. So it's not plegia. So it is hemiparesis, right-sided hemiparesis.
Yes.
And patient is also
Yes,
having
sir.
Broca's aphasia because she is able to understand but cannot express. Okay.
Yes, sir.
So patient is having Broca's aphasia and patient is having right-sided hemiparesis. So that is the only neurological deficit you have found out, is it not?
Yes, sir.
So this answers what? Then where is the lesion?
Since there is complete right-sided hemiparesis with language dysfunction, so I think the lesion can be in the cortex, sir.
No, usually if the lesion is in the cortex, what happens? Patient will have monoparesis, like patiobrachial monoparesis or monoplegia. Because in the cortex is very big. So it must be a huge infarct or huge lesion. So patient will have very severe neurological manifestation. So it's unlikely to be cortex. The motor fibers are compactly situated where in the internal capsule and also in the brain stem to some extent. So,
yes, sir.
Internal capsule.
Yes, sir.
So in the internal capsule, if the lesion is there, and usually 36% of the lesions occur the ischemic strokes in the internal capsule only. So if the lesion is in the internal capsule, so the whole left half of the body will be affected. From the cortex, the next system is corona radiata. Even there also, you can't get a whole left or right-sided weakness or inability to move. So it must be in the internal capsule. There is a calmness. And so
Yes,
the next question is, it is internal capsule involvement. Which internal capsule? Right or left?
sir, left internal capsule.
Very good. Left internal capsule, because the fibers cross over to the opposite side. The motor fibers cross over to the opposite side at the lower end of the medulla oblongata. Okay,
Yes,
so it is the left internal capsule. The lesion is there. And what could be the cause? It is middle cerebral artery involvement. Why middle cerebral artery? Upper limb is more affected than the lower limb. So that's
yes,
why
sir.
it is the middle cerebral artery. I will say it is internal carotid artery. What is your point against it?
So there is no history of blackouts or blindness,
Very
no
good.
history of headache.
Usually you get, if it is internal capsular lesion, because of the retinal artery taking origin from the internal carotid artery. So you get what is known as amaurosis fugax, or blackouts, or
Yes, sir.
loss of vision is in the left eye. So it's unlikely to be internal capsule. So it must be middle cerebral artery. So you don't think it is vertebrobasilar?
Yes.
Yeah, because
Sir,
it happens.
vertebrobasilar weakness will be on the both the side.
Very good. It will be on the both the sides, and I told you there will be nausea, giddiness, hiccups, vertigo. So patient will have
Yes, sir.
bladder bowel incontinence, and sensory involvement also is more common if it is in the vertebrobasilar system involvement. So now you have answered what and where. Now next is why. The question is why.
Yes. Why it can be due to ischemic stroke, sir, thrombotic.
Very good. So why do you say so?
Sir, first it is ischemic, not hemorrhagic, because there is no feature suggestive of raised intracranial tension like headache, vomiting, and blurring of vision, loss of consciousness. And in ischemic, I suspect thrombotic more than embolic, because thrombotic strokes are most common in the early morning, sir. And in embolic strokes are most common during the activity, sir. And there is a chronic history of diabetes and elderly individual with hypertension. These all are the risk factors for the atherosclerosis and thrombus to form, sir. So that adds to the thrombotic stroke, sir.
So thrombotic, as you said clearly, it's early morning. Usually patient will have stroke. That's number one. Number two, usually they will have recovery. So there will be recovery, but it will not be a 100% recovery as you get in embolic stroke, because embolus gets disintegrated, unlike the thrombotic, which persists. And next is thrombotic strokes will have, about 40% of the patients will have TIAs, transient ischemic attacks. Unlike in this patient didn't have any TIAs. Not maybe. Can you tell me what is TIA? Transient ischemic attack.
Sir, it is acute focal neurological deficit which lasts less than 1 hour with no residual involvement, and there is no detectable lesion in the investigations such as MRIs.
Okay, so it's not 1 hour. Patient recovers completely within 24 hours. Acute neurological deficit, recovering completely within 24 hours is transient ischemic attack. So this patient is having recovery. This patient is having recovery, no TIAs, but there are risk factors like diabetes and hypertension. So one more point which is missing in this patient is stroke in evolution. Usually a thrombotic stroke evolves over a period of time. Say, for example, early morning when he gets up to, or when she gets up to go to the pass urine, patient will first notice weakness in the upper limb. Then by afternoon, she will notice weakness in the lower limb also. So that's how it progresses or evolves over a period of time, but not necessarily in all patients. If there is a block, instantaneous or a huge thrombus formation suddenly, it can be sudden also. But usually stroke in evolution is one important point in a thrombotic lesion, and usually TIAs are common in thrombotic lesions. Unlike in embolic usually you said clearly that it is during activity, it's very common. Actually, it is activity you get hemorrhage more commonly. So patient can have any period of any time in embolic stroke, and usually it occurs, embolism occurs in various areas, whereas thrombosis occurs, for example, if left middle cerebral artery is affected, it will happen only in the left middle cerebral artery. Embolic, say for example, if embolic stroke, embolus is coming from heart, it can go to left middle cerebral artery, it can go to right middle cerebral artery, it can go anywhere, is it not?
Yes, sir.
So that is why, and it will be a shower of emboli. It won't be one. So it can be multiple also. So, and they can also have TIA in embolic stroke. So they can have multiple, like shower going, multiple areas can be affected. So that's how you differentiate between a embolic and a thrombotic stroke. There are other few ischemic strokes. You know which are they? One is hypoperfusion. Say for example, if somebody develops, yeah.
Yes, sir.
Tell me.
No, sir. I was about to tell lacunar stroke.
No. Lacunar infarcts are part of ischemic only. Where what I am telling is hypoperfusion. Say, for example, if a patient develops hypotension due to burns, due to gastroenteritis, due to dehydration of any cause, like heat stroke. So what he develops, he also develops stroke. How? Especially in the watershed zones. Watershed zones there are longitudinal watershed zones in the spinal cord. There is horizontal watershed zones. If you take a section of the spinal cord where the anterospinal artery and posterior spinal artery, the end, that area is watershed, where you see the lateral spinothalamic tract and the pyramidal tract in the spinal cord. Vertically also, see, you have got anterior spinal artery. See, anterior spinal artery, they are the branches arising from the vertebral artery, and they unite to form anterior spinal artery. Anterior spinal artery. So that doesn't, though it flows up to the end of the spinal cord, it gets reinforcement at various places. So if anterior spinal artery is blocked, or because of the hypotension, if there is no flow, there is a watershed zone at the junction of cervical spinal cord and the thoracic spinal cord. So in that place, one can also have involvement of the spinal cord and can develop paraparesis. So like that. So this is about the hypoperfusion. There is one more entity in ischemic stroke, what is known as the hypercoagulability states. Can you name one? Already you have mentioned few. Can you name one?
Hyperhomocystinemia, protein C and protein S deficiency, antithrombin 3 deficiency,
Yes.
and
Very good.
hypertriglyceridemia.
Very good. To add list, thrombotic thrombocytopenic purpura. Okay. So these are all hypercoagulation syndrome where one also can develop ischemic stroke. Now you have mentioned clearly about ischemic stroke, how it presents, and an embolic stroke, how it presents. What about hemorrhage?
Sir, hemorrhagic stroke, there will be feature suggestive of raised intracranial tension, like loss of consciousness, altered sensorium, headache. If it is subarachnoid hemorrhage, there will be tension, thunderstorm headache, and vomiting, projectile vomiting, neck rigidity, signs of meningeal irritations like Brudzinski and Kerning signs, and these features will be there, sir.
So they can have seizures, and they can have loss of consciousness. Then they can have sudden onset, and usually bladder bowel involvement will be there. Okay. Then recovery will not be there like in this patient. Whereas in embolic stroke, the recovery is usually 100%, and it will be very rapid. It comes like a bolt from the blue and recovers fast also. So in hemorrhagic stroke, the prognosis is very poor and mortality is very high. Okay.
Yes, sir. Yes, sir.
Compared to thrombotic or embolic stroke. And there is one more entity, what is known as hemorrhagic transformation of a thrombotic stroke. What do you mean by that?
Sir, don't know.
Okay, I'll tell you. See, whenever there is a thrombosis, what happens to the brain? Infarction will be
hypoxia in that region.
Hypoxia and infarction will be there. Infarction, like myocardial infarction, coronary artery is blocked. Even the blood vessels are also affected, is it not?
Yes,
or infarcted in that area. So subsequently, when recirculation takes place, reperfusion takes place, there is no continuity in the vascular tree. So what happens? Blood enters into the infarcted area. So what happens here? It becomes, the infarct becomes now a hemorrhagic stroke, or hemorrhagic transformation of an infarct takes place. And here you will treat this condition as similar to that of an hemorrhage only, intracerebral hemorrhagic stroke. Okay, so now you are clearly learned about what is an hemorrhagic stroke, what is an embolic stroke, what is thrombosis also.
Yes,
right?
Sir. Yes, sir.
So any questions in this? Now you answered what and where. Why you have told partially. like thrombosis. So it doesn't end there. You have to tell the risk factors also. What are all the risk factors this patient is having?
Diabetic mellitus, first is age, elderly age group, and diabetic mellitus on irregular treatment, and recently diagnosed as hypertensive.
So one is diabetes mellitus. We don't know whether it was a controlled diabetes or uncontrolled diabetes, what medicine she was taking for diabetes, whether it was regular or irregular. So we don't know that. So diabetes mellitus is a risk factor, and hypertension recently detected to be hypertensive and elderly. Okay. Now, can you tell the diagnosis at this stage?
Diagnosis stage. She's in the stage of recovery, sir.
Yeah, recovery is there. No, we have completed all that. So, what patient is having? Right side hemiparesis with motor aphasia. Okay, due to thrombosis involving left middle cerebral artery territory.
Yes, sir.
Okay. As a result of due to hypertension and diabetes mellitus. So this should be your diagnosis.
Yes, sir.
Now we will go to the examination.
Yes, sir.
So any questions at this stage you can ask. Any questions or any doubts you have got at this stage, you can ask, or also others also, if they can also ask.
Sir, YouTube question, sir. Can we give prophylactic anticoagulation from day 1 of histamine?
For this patient. So there is no point if the patient day 1 we cannot give. So if patient comes within 4.5 hours of the stroke, then you can give tissue plasminogen activator, RTPA, and that day, one day after 24 hours, you have to give anticoagulation. You cannot give on the same day.
Yes, sir.
For this patient, since she has come after 4 days of the involvement, there's no point in giving anticoagulation. You can go ahead with the antiplatelet drugs, like what she is getting, aspirin, clopidogrel. So that can be continued rather than giving anticoagulation. If it is an embolic stroke, definitely we would have gone, say, for example, a cardiac patient coming to you with hemiparesis, then definitely we would have given anticoagulation. So, but here, since it looks more like a thrombotic, no past history of any cardiac valvular heart disease or ischemic heart disease, so we usually don't go ahead with the anticoagulation. If you are given antithrombotic therapy like RTPA, then after 24 hours of RTPA, you can give anticoagulation. But here in this patient, presently doesn't need any anticoagulation. I think, is that clear?
Yes, sir.
Okay, any question from your side, Tejaswini?
No, sir.
Oh, only 2 people will not have questions. You know who are they?
Who knows all, who doesn't understand anything.
Yeah. So which group you belong? Okay, fine. Continue with examination.
Yes, sir. Examination. General physical examination. Here is elderly female, conscious, cooperative, well-oriented to time, place, and person. Height 155 centimeter, weight 45 kg. I didn't calculate BMI. Poorly built and nourished. No history. No pallor, icterus, clubbing, cyanosis, generalized lymphadenopathy, and pedal edema. No resting nystagmus, squint or ptosis. No engorged neck veins. No evidence of xanthomas. No evidence of infective endocarditis, no skin markers. Then vitals, pulse rate 74 beats per minute, regular rhythm, normal volume, normal character. Arterial wall is not thickened. Peripheral pulses are felt with normal intensity bilaterally. There is no radial delay or radiofemoral delay. Blood pressure measured on the right brachial artery, supine in the supine position with 140 by 90 millimeter Hg. Respiratory rate of 18 cycles per minute, predominantly thoraco-abdominal pattern. Depth is normal. No use of accessory muscles of respiration. Axillary temperature of 37.3 degrees Celsius and jugular venous pulse is normal. Then systemic examination of central nervous system.
1 minute.
Higher.
Did you look for any xanthomas?
Yes, sir. No evidence of xanthomas.
No thickened vessels,
Sir?
you told me. No arterial wall is not thickened, is it not? All peripheral pulses felt?
Yes, sir.
How do you look for internal
Yes,
carotid
sir. All
artery?
peripheral pulses felt.
How do you look for
Internal
carotid artery?
carotid artery. Sir, internal carotid artery is bimanual, sir. On per oral examination in the tonsillar fossa, we have to keep our finger and we should feel for the pulsation of internal carotid artery.
Very good. So we have to feel for internal carotid by keeping our hand over the tonsillar fossa. Fine. So that's about general physical examination. Next, systemic examination.
Systemic examination of central nervous system, higher mental functions, conscious, coherent, cooperative, well oriented to time, place, and person, appearance and behavior appropriate, emotionally stable, general intelligence cannot be assessed, recent, immediate, and remote memory is intact, speech output, comprehension is normal, repetition absent, fluency reduced, naming lost, not able to read aloud and write, and patient is right-handed individual.
Just quickly, can you tell me how do you assess given individual is right-handed or left-handed?
Sir, by history, I will ask which predominant hand she will use for most of her day-to-day activities, sir.
Like?
And like doing any work, normal day-to-day activities, she will be using the predominant hand first.
Like eating, writing?
Yes, sir. Eating, writing, and while cooking the food, normally they cook the food, most commonly use right hand, sir.
It's not any work. It is skilled works like combing the hair, buttoning the shirt, like viewing through the keyhole. Okay. Then viewing through the microscope, monocular microscope. Then which hand is more comfortable while using the mobile phone? Okay. Then winking the eye,
Yes,
which eye prefers to wink the eye. So these things you should ask rather than asking any movement. Okay. So that's about the which-handed the person is. And higher mental functions, not much contributory. Our patient is almost normal, is it not, as far as higher mental functions are concerned?
Yes, sir.
Okay, now next.
Sir, cranial nerve examination. Olfactory nerve is normal and optic nerve.
Speech and language.
Speech I told in higher mental
Speech
function.
and language you didn't tell me.
Speech, sir.
No. Okay.
Comprehension is normal.
Speech separately.
Yes, sir.
Only expression is affected. Okay, fine. So it's motor aphasia.
Yes, sir.
Okay, continue.
Sir, cranial nerve
Tejaswini?
examination.
Yes.
Yes, sir. Hello.
Yeah, continue. Please continue.
Yes, sir. Cranial nerve examination. Olfactory nerve is normal. Optic nerve, visual field is normal. Visual acuity is by counting fingers. Color vision cannot be assessed. Pupil is round, reactive, and 4 millimeter in size on both the sides. And third, fourth, and sixth cranial nerve, normal ocular motility in all the cardinal direction. Pupillary reflexes, both direct and indirect light reflex is normal. Accommodation reflex is normal. Then trigeminal nerve, sensory, ophthalmic, maxillary, and mandibular division is normal. Motor examination, that is for masseter and temporalis and pterygoid muscle is normal. Jaw jerk is absent. Facial nerve, on the right side, forehead wrinkling is present, able to close the eyes. There is loss of nasolabial fold. Angle of the mouth is deviated to left side, able to blow, and in anterior two-third of the tongue, taste sensation is normal. Sir. Vestibulocochlear nerve, normal hearing for the conversation, and there is no nystagmus. 9th and 10th cranial nerve, normal soft palate motility. There is no nasal regurgitation. Gag reflex is normal. And spinal accessory nerve, normal power of sternocleidomastoid and trapezius muscle. Hypoglossal nerve, no deviation on protrusion of the tongue, no atrophy of the tongue. There is no fasciculations, and power of the tongue is normal. And from this, my impression is right-sided upper motor neuron facial palsy.
Okay, so cranial nerve involvement, as far as you have got only right UMN facial palsy, is it not?
Yes, sir.
Why upper half of the face is spared?
Because it has bilateral innervation, sir.
Okay. Why other motor cranial nerves are not affected?
Sir, all the cranial nerves has bilateral innervation except the facial nerve in the lower half of the nucleus, sir.
Very good. So it's only the lower half of the face that is unilaterally represented. See, in a patient who comes to you with a stroke, acute stroke comes to you, when you examine, even the upper half also will be slightly weak. Even wrinkling of the forehead also you see. Even in this patient, if you keenly observe, the upper half also appears to be slightly, not that much wrinkling. If you see the photo that is given to you. So why that? After some time, one can, can see usually what happens. Say, for example, you are getting 1,000 rupees as pocket money every month. Okay. Suddenly, due to recession or COVID, it is reduced to 500 rupees by your parents. It is reduced to 500 rupees. So now, what happens to you? You will be a little bit perturbed how to spend this 500 rupees whole month. Is it not? So similarly here,
yes, sir.
Fibers are suddenly reduced. Till the functioning fibers to take over the function, it takes some time. So since this patient has come to us 10 days after the stroke, so that is why you don't see any upper half involvement, but except you can still, if you see the photograph very keenly, you can make out there is slight weakness. Okay. Yes, continue.
Yes,
so there is UMN facial palsy is there. There is motor aphasia is there.
Yes, sir. Then motor examination, attitude in supine position, both upper and lower limbs are extended, and nutrition, in there is no atrophy noted. Then tone, in the right side there is hypertonia in both upper limb at arm, forearm, and lower limb at thigh and leg. There is spasticity is noted. Then the power, And power at
So
each
what is the
joint in the
difference
upper
between
limb.
hypertonia and spasticity? No, 1 minute, 1 minute, 1 minute. Huh?
Sir,
What is the
spasticity is
difference
a
between
type of
hypertonia and spasticity?
hypertonia.
Very good. So what is
Sir,
that type?
spasticity is a type of spasticity. There is only one group of the muscles are involved. That is anti-gravity muscles, sir. In upper limb, the flexors, and in the lower limb, the extensors. The tone will be more increased, sir.
Okay, so it is the anti-gravity group of muscles where the tone will be increased. You get what is known as spasticity, or we also we used to call this earlier as clasp knife type of spasticity. Okay, so spasticity is usually in the anti-gravity group of muscles. So, okay, hypertonia can be both. It can be in the flexors or extensors also. We get in conditions like extrapyramidal lesions, like Parkinsonism. So you get hypertonia, or that we call it as
Rigidity, sir.
Very good. So it's called as rigidity. Fine. So this patient is having spasticity in the anti-gravity group of muscles on the right side. Okay. Power is 3/5 you said on the right side.
Yes, sir. Yes, sir. Power is 3/5, sir.
Okay. Power is 3/5.
Then reflexes, sir. Superficial
Okay.
reflexes, corneal conjunctival reflexes are present on the right side, whereas abdominal reflexes is absent, jaw jerk is absent, and plantar reflex is extensor response, sir.
Okay.
Then
What
the
is the
deep
reflex which
reflexes,
is
biceps.
1 minute? What is the reflex that is akin to plantar reflex in the upper limb?
That is Hoffman's reflex and Wartenberg sign, sir.
Hoffman's is
Hello?
different. Hoffman's only tells you there is increased tone. Hoffman's tells you only there is increased tone, whereas Wartenberg's is akin or similar to plantar reflex in the lower limb. You know how to do the Wartenberg sign?
Yes, sir. Wartenberg sign, we have to interlock the fingers of the patient finger with the examiner finger. Then we try to move apart. There will be flexion and adduction of the thumbs. Sir.
Very good. So, and it crosses the midline. So you have to interlock the fingers, not the thumb, so with the patient, and ask him to pull your fingers. So when you do that, so the thumb normally stays where it is, or it extends in a normal person, whereas in a patient who is having pyramidal lesion, it will cross the midline. Okay, so that's why that is known as Wartenberg sign is positive in the upper limb. So that clearly tells you that it is sign in the lower limb. DTRs.
So deep tendon reflexes are exaggerated in the right side of the body, sir.
Okay. So deep tendon reflexes are all exaggerated on the right side. So they are brisk. Yes, you can say brisk also, or exaggerated. So this patient up till now is having UMN facial palsy, motor aphasia, UMN facial palsy, and spasticity, weakness of the right half of the body, and abdominal absent, plantar is extensor. You didn't do Wartenberg sign on the right side. Okay. Then DTR are exaggerated. So anything else? Next, what you have examined?
Then coordination.
Okay.
Coordination, sir. finger nose test and finger nose finger test and heel to ear test, heel to knee test, which cannot be assessed in the right side and it is normal in the left side, sir.
Very
and
good.
involuntary movements are absent.
Okay, fine. Because it's only grade
In
3
sensory system
Fine.
sensory system examination is normal, sir.
Sensory also you should examine. Why?
Why? Because in internal capsule there can be hemi-anesthesia, sir. So we have to examine even sensory nervous system.
So there can be hemi-anesthesia in internal capsular lesion because you know that just posterior to the pyramidal fibers you are having sensory radiation. Then behind that you are having optic radiation. So genu and anterior 1/3 you have got pyramidal fibers. Middle 1/3 you have got sensory radiation. Then posterior 1/3 you have got optic radiation. So that is why you have to examine sensory also. Fine. Then sensory system is normal.
Yes, sir. Both posterior column and spinothalamic sensations are intact, and then cortical sensations. Patient is able to localize tactile localization and 2-point discrimination. That stereognosis and graphesthesia that cannot be completely assessed, sir, since patient cannot speak properly.
Okay.
Then cerebellar function test, cerebellar system found to be normal, sir. There is no titubation, nystagmus, there is no post pointing and dystidocokinesia, no intentional tremors, no rebound phenomena and pendular knee jerk, sir.
Pendular knee jerk is due to what?
Then
Pendular knee jerk is due to what? It is because of hypotonia. Rebound phenomena and pendular knee jerk are due to hypotonia. So anyway, this patient doesn't have hypotonia on the right side. So the question of pendular knee jerk doesn't arise. Okay.
Yes, sir.
Okay, next.
Then signs of meningeal irritation absent, examination of skull and spine normal, auscultation of neck and over the skull. There is no bruit heard over the supraclavicular fossa, no bruit over the skull, and no carotid bruit. And stance and gait, patient is unable to stand or walk on his own. Other system examination, cardiovascular system, yes, first and second heart sound heard with no murmur. Respiratory system examination, normal vesicular breath sounds heard. Per abdomen examination, soft and non-tender, no organomegaly. And in summary,
Okay,
sir.
now before going to summary, the
Yes, sir.
speech is slurred, he said. But,
Yes, sir.
while examining, you said that patient is able to understand but cannot express.
Yes,
Is
sir.
it not?
Yes, sir.
Reception is normal. Only thing is the expressive or the motor component is affected. What is the difference? See, where is the motor center for speech?
Sir, Broca's area number 40, 41 and 42 in temporal region, sir, in dominant hemisphere, sir.
Is it temporal or frontal? Posterior part of...
Sir, Broca's area is frontal, sir.
Broca's area is situated in the frontal lobe, posterior part of third frontal convolution. So that is area 44. It's not temporal. Temporal is sensory.
Wernicke's.
Okay.
Yes, sir.
Wernicke's. You
Yes,
get Wernicke's. Broca's area. See, in this patient, you are suspecting it is a lesion in the internal capsule, is it not?
Yes, sir.
Why speech is affected?
Sir, the speech area that also has the same blood supply from middle cerebral artery, sir.
No,
Middle cerebral artery
usually
superior division supplies Broca's area.
I told capsule with lenticular striate artery. Huh?
Hello,
So
sir.
patient usually if it is an internal capsule also lesion, patient can have motor aphasia. The only thing is recovery. Recovery will be good. Say for example,
Yes,
if
sir.
Broca's area is affected, patient will have persistent speech disorder. Whereas if it is an internal capsular lesion, initially he will have motor aphasia, but subsequently it recovers. It becomes almost normal. Sometimes there may be slight slurring, but it will be almost normal. Unlike a Broca's area that is affected. So that's about the
Yes, sir.
speech in this treatment. See, patient is already developing slurred speech. So likely that she will further recover because it's only 10 days old, is it not?
Yes, sir.
Okay, now you summarize. We'll see.
Sir, summary. Elderly female, chronic diabetic and hypertensive on irregular treatment, presented with acute onset of weakness of right upper limb more than right lower limb, associated with weakness of right lower half of the face and slurring of speech of 10 days duration, currently non-progressive. She doesn't have any symptoms suggesting involvement of higher motor functions, cranial nerves, brainstem, cerebellum, sensory system, bowel or bladder. On examination, she has right-sided hemiparesis with right upper motor neuron facial palsy, Broca's aphasia, without the involvement of other cranial nerves or alteration in the higher motor function, brainstem or cerebellar function. So my diagnosis, right side hemiparesis with right UMN 7th cranial nerve palsy with
See,
Broca's
now you
aphasia due to
Tejaswini, see, usually
Yes.
whenever we present a neurological patient, we tell what are all the neurological deficits patient is having.
Yes, sir.
Okay.
Yes, sir.
Right-sided hemiparesis. That includes even UMN facial palsy also, but you can also mention right UMN facial palsy. Then motor aphasia, okay, and diabetic
Yes, sir.
hypertensive. That's all. Anything more?
No, sir.
Okay, now you have to tell
Hello.
this. Now you have to tell about this one. One is what is your clinical diagnosis? Next is what's your pathological diagnosis? What's your anatomical diagnosis?
Anatomical.
Then what is the etiological diagnosis? This completes your diagnosis. Instead of telling,
Yes, sir.
one sentence, you can tell what is the clinical diagnosis.
Clinical diagnosis, right-sided hemiparesis with right UMN 7th nerve palsy.
Yeah, UMN facial palsy. Okay, that's your clinical diagnosis. Then what is the pathological diagnosis?
Sir, thrombotic ischemic stroke of left cortex. Sir.
Ischemic stroke due to thrombosis of left MCA territory. You can't tell the specifically which vessel. You can just mention right MCA territory.
Yes.
Okay. So then what is the anatomical diagnosis?
Sir, internal capsule, sir.
So left internal capsular lesion.
Left internal capsule.
We have discussed already. If patient is having cortical or corona radiata involvement, you will have monoparesis. You will not have a complete hemiparesis like this. That is number one. If it is a brainstem lesion, usually happens what? Patient will have cranial nerve, a LMN, lower motor neuron type of cranial nerve palsy on one side. Opposite side, he will have hemiparesis because of the crossover of fibers. Okay. So
Yes,
this
sir.
we call it as
Crossed hemiplegia.
Okay. We call it as crossed hemiplegia because cranial nerve involvement on the same side will have pyramidal lesion. So this we call it as crossed hemiplegia. So it's unlikely to be a brainstem lesion. So most probably it is an internal capsular lesion on the left side. Okay.
Yes, sir.
Just to come towards
Hello,
crossed
sir.
hemiplegia.
Voice is not.
You got any? What is
Hello, sir.
cruciate
Voice is
hemiplegia?
not audible. Sir, cruciate is one
What
side
is?
upper limb involvement, other side lower limb involvement, sir.
Very good. So where do you get the? Where is the lesion in this case?
That is.
In cruciate hemiplegia, lesion is in medulla oblongata, where the fibers cross over. That is lower part of the medulla oblongata. When there is a lesion there, patient will have cruciate hemiplegia. One side there will be upper limb involvement, opposite side there will be lower limb involvement. Okay.
Yes, sir. Yes, sir.
So now you have told us about clinical diagnosis, pathological diagnosis, anatomical diagnosis. What is the etiological diagnosis?
Sir, etiology, elderly age group with
So elderly
yes,
person, number
elderly
one.
age group with diabetic mellitus.
Diabetes mellitus.
And diabetic mellitus.
And hypertension.
And hypertension, sir.
Okay, so
yes, sir.
This completes your neurological diagnosis.
Yes, sir.
Any questions or any doubts as far as the history examination and the diagnosis?
Sir, while checking power, sir. Hello.
Yes, continue.
Sir, sir, while checking power, we normally ask the patient to raise the lower limb or raise the upper limb. If the patient is able to do, we will assess it as grade 3. But do we have to check each muscle individually, sir?
See,
like each supraspinatus deltoid.
Very good. So this is a very good question you have asked me. See, in a patient like this, where we know that this is a vascular lesion and the patient is having hemiparesis, so we usually don't check individual muscles because it is time consuming and you have to do a lot of other tests also. In neurology, it is like an arithmetic. The patient examination of a neurological patient is like arithmetics, where you go point by point and usually you will be led to the diagnosis. See, our examining a patient, what is our intention? You have to arrive at a diagnosis as quickly as possible and you have to treat. That's our intention. So if you go on examining individual muscles, the whatever time that is given to you in the examination, probably we give about 1 hour. So it's impossible to complete. And individual muscles examination we give importance when examine individually the muscles. Okay. So otherwise we usually don't examine individually the muscles. So it's in the group. So either flexors Questions are, so that's how we examine here when you think it is a vascular lesion and an hemiparesis or hemiplegia. Is that clear?
Yes. Yes, sir.
Okay. Anybody else? Okay, now how are you going to manage this patient who has come to you after 10 days of the initial lesion? So how are you going to manage this
Sir,
patient?
we'll go with investigations such as MRI of the brain or CT of the brain to localize the lesion, and normal routine investigations such as complete blood count and bleeding, coagulation profile, bleeding time, clotting time, prothrombin time, and activate partial thromboplastin time. Then even I will do, if we suspect any cardiac diseases and all, we will do routine ECG, and these all are the investigations, sir, and
Echocardiography
treatment
also.
since the patient. Yes, sir.
Patient is a diabetic
And
and hypertensive also. So you will do an echocardiography also.
yes, sir.
Okay.
Then
So MRI or CT scan. Yes. Continue.
Treatment option since
Treatment.
the patient has come after 4 days to the hospital, so there is no role of giving thrombolysis with RTPA, recombinant tissue plasminogen activator. We will assess the patient. If the patient is stable, there is no transformation to hemorrhagic stroke, then we can start her with antiplatelet drugs such as aspirin and clopidogrel, and evaluating her blood pressure to a minimal level. Should continue her on regular antihypertensive and anti-diabetic medications.
See, our BP, when they checked in the hospital, it is 140/90, is it not? Or when you checked, it is 140/90. So
When I check,
you still further
yes,
reduce it or you continue?
Sir, 140/90 is still is a slight higher level, sir. So, but normal antihypertensive medication is enough to maintain her blood pressure, sir.
So you have to you should not further reduce the blood pressure because the watershed zone or the penumbra, what you call it as, there is a stroke, a dead tissue, infarcted area surrounded by a viable area which is vulnerable for infarction. So that we have to save. So whereas in a patient of myocardial infarction or in a patient who is having renal involvement, slow is better. But here we usually don't bring it down rapidly. That is one thing. Diabetes has to be controlled. So we usually control the diabetes. We don't know what is our diabetic state. So what is the dose of aspirin you give?
Sir, aspirin 75 mg, sir.
No, usually in acute stroke, we give 325 milligrams
300 mg.
aspirin. So, and clopidogrel?
Sir, clopidogrel 325 mg, I think. Not sure, sir.
No. Clopidogrel, we give 300 milligrams stat. That is 4 tablets stat, followed by 75 mg daily. Okay. So this is double antiplatelet therapy, what we call it as. And other things are control of hypertension, control of diabetes, then taking care of nutrition, bowel, bladder, okay, back. So patient should not develop bed sores. Physiotherapy is important. So you have to give physiotherapy. So that patient will not develop contractures So you have to do physiotherapy. This, as far as this patient is concerned. If she had come early, within 4.5 hours of the, you would have given RTP, recombinant
Thrombolytic
tissue
therapy,
plasminogen
sir.
activator.
RT plus.
Thrombolytic therapy. What is the dose? It is
Sir,
0.9
0.9
milligrams per
mg
kg
per
body weight,
kg body weight.
a maximum of
10% bolus, sir, and 90% as infusion.
10% bolus is given in 10 minutes and remaining 90% is given in the next 1 hour. Okay. And there are few conditions before giving thrombolytic therapy that patient has to fulfill all that. Otherwise, you should not use this because it can cause severe hemorrhage. So, any questions?
Yes,
Any
sir.
more questions?
Patient should be more than 18 years of old.
Continue.
No, sir.
Continue.
Patient should be more than 18 years of old, and while doing CT scan, there should not be any hemorrhage, or if there is cerebral edema in the MCA territory, it should not be more than 1/3, and there should not be any bleeding disorder, or patient should not have recent myocardial infarction within a week, and there should not be GI bleeds.
And any procedures shouldn't have undergone within 1 week's time. Okay. So that's about the
Yes, sir.
thrombolytic therapy and management of this patient in particular. We can only use antiplatelet, control of blood pressure and diabetes, and physiotherapy.
Yes, sir.
In thrombosis, you can also do endarterectomy. So endarterectomy also is done, but there is some risk it can precipitate further stroke. So nowadays, not much done. Okay. Any more questions?
No, sir.
Good evening, sir. There are few questions on YouTube, sir.
Yeah, please.
They've asked, can we give prophylactic anticoagulation from day 1 of ischemic stroke?
No, this question I think already I answered. Usually we give anticoagulants after thrombolytic therapy, 24 hours after thrombolytic therapy. And usually we don't give in a ischemic stroke like thrombotic. We give in embolic stroke. Anticoagulants should be started on day 1 in an embolic stroke, embolic ischemic stroke, not in a thrombotic or atherothrombotic stroke. Is that clear?
Yes, sir. Another question is, how to check power if patient is disoriented and not following commands?
Okay, so you can lift the hand, whether it falls to the bed, or pinch him, so whether he moves the limb. So that way you have to check. If in an unconscious patient, it's very difficult to check the power, and you can, only few things can be done. Like, you cannot exactly tell what it is, but flickering movements you can see definitely. So flickering movements are there, or whether he can move himself voluntarily. So that way you have to check rather than checking, regularly, like in a conscious patient. It's not possible in an unconscious patient. Is that clear?
Yes, sir.
Yes, sir.
One question they've asked was, how to differentiate between spasticity and rigidity?
Okay. I think we have answered this question. Tejaswini has told very nicely. Spasticity you see only in anti-gravity group of muscles, like flexors in the upper limb, extensors in the lower limb. Whereas rigidity you get in both the groups, flexors, extensors in both the limbs. So when you try to flex the limb also, there will be increased resistance. What is tone? Tone is a passive resistance offered to the movement. So whenever you try to move the limb, a passive resistance is offered. So spasticity, you get what is known as class 9. So in the flexors in the upper limb, like say, for example, when you try to extend the upper limb, initially there will be resistance, then suddenly it gives way. Whereas rigidity, it can be continuous. So it is throughout. There are, once again, there are two types of rigidity, what is known as lead pipe rigidity and cogwheel rigidity. Only the difference between the two is when there are tremors in between, like you get in Parkinsonism this, when there are tremors in between, there will be just like a cogwheel movement, no? Resistance giving way, resistance giving way. So that is what you get resistance. So rigidity is seen in both the groups, flexors as well as extensors, whereas spasticity you see in only one group, like flexors in the upper limb and extensors in the lower limb. Okay, next. Any more? Any other question?
No, sir.
Okay, Tejaswini. You have done really good job.
Sir.
You have presented very nicely. I appreciate you. All the best.
Yes, sir. Thank you, sir. Thank you so much for guiding us, sir. Thank
Okay,
you,
shall
sir.
we close the class? Okay,
Sir,
all the best. Shall we close the class?
it was a wonderful session, sir. Any
Okay.
concluding remarks, sir?
As far as the case presentation is concerned, or on what aspect?
Yes, sir. Case presentation regard any improvements
Yeah.
to be suggested.
Okay, so this is, I mean, for undergraduates, this is a very good case you have selected, and she has presented very nicely, and she has answered the questions also nicely. I think there is a lot of things to be taken home from this presentation for other students, and we can do many more cases like this. All the exam, I mean, patients that are kept in the examination. So other systems also. And I really liked your way of approach. Only thing it should, I mean, I felt it's only off the record I'm telling. I felt that there was little bit, we could make out that this is a tailor-made case. Do you agree with me?
Hello, sir.
Can you hear me?
Yes, sir. We can hear you, sir.
Is it a real patient or a tailor-made patient? Is it a real patient
sir.
you have presented or? Okay.
Real, sir. The
So it should
last
be,
exam case of mine, sir.
Okay. So it is, something like, the case, I mean, history, examination, everything is just, usually there will be little difference. And what I am trying to tell is, in clinical medicine, 2 plus 2 will never be 4. Either it will be 3 or it will be 5. So it will never be, almost like, this is a very classical presentation of a patient of thrombotic stroke. I don't think anybody should have any difficulty in examining or diagnosing this. So keep some difficult cases also where you have to use your clinical acumen in diagnosing. Okay, fine. I think we'll
Thank you so
conclude
much.
at this stage. Thank you very
Thank-
much.
Thank you so much, sir.
Thank
It
you.
was indeed a very comprehensive clinical class, sir. We could learn a lot from you. Thank you for your valuable inputs and guiding us all. Thank you very much, sir. I also thank
Thank you. I
Ms.
think we'll close the
Tejaswini
session.
for the wonderful presentation. I thank all the participants for the active participation.
Yes.
Thank you, one and all.
Thank you, sir.